Welcome to the joint meeting of the American Society for Microbiology's 55th Interscience Conference on Antimicrobial Agents and Chemotherapy and the International Society of Chemotherapy's International Congress of Chemotherapy. For those of you joining us via the web, welcome. For those of you joining us for the first time, this is a meeting whose focus is on antibiotic resistance, new antibiotic development, and antibiotic stewardship. This joint ICAAC meeting presents an unmatched opportunity for discussion and cross-collaboration amongst our globe's leading scientists and healthcare providers. I'm Michael Schmidt from ASM's This Week in Microbiology, and together with the program committee, we've asked a number of the authors presenting their science at this meeting to join us live and have the opportunity to take your questions. All you need to do is present yourself at the microphone or use the hashtag ASM Live or comment via our chat room. So let's welcome our first guest here this morning, Dr. Maggie Monogue and Dr. Jessica Ortwine. I'd like to thank you all for agreeing to be the first ones for this year's ASM Live. And why don't you introduce yourself? Tell us where you're from, a little bit about yourself, so we'll get to know what you're going to do.
Okay. Hi, everyone. My name is Maggie Monogue. I went to pharmacy school at the University of Texas College of Pharmacy. I did my PGY1 residency at Parkland Health and Hospital System in Dallas, Texas, and now I'm a current infectious disease fellow at Hartford Hospital.
All right, and I am Jessica Ortwine. I did my training, my first year training at Baptist Hospital in Memphis, my second year ID training in Detroit, and now I am one of the infectious disease pharmacy specialists at Parkland Hospital in Dallas.
And you guys are going to share with us some exciting results that you're going to present tomorrow during a poster session from 11 to 1, and it's poster board number S912, so you all that are here can come in and visit it, and it's going to be tomorrow on Saturday. And you're going to talk about a cost-effective alternative to the current standard of therapy in treating staphylococcal bloodstream infections. So why don't you share a little bit about the background behind how you began this study and the question that your study asked?
So what we were looking at are patients who are admitted to our hospital with methicillin susceptible Staph aureus bacteremia, which is basically when you have the bacteria in the blood. And currently the standard of care is nafcillin, which is an antibiotic. But we wanted to look at the outcomes of nafcillin compared to a different antibiotic, cefazolin, in treating this bacteremia. The main question we wanted to see is cefazolin as effective as nafcillin, because cefazolin is actually more cost effective and therefore could save not only patients money but the healthcare system money as well.
Now, what's different about nafcillin and cefazolin? They're, from what I remember, they're both beta-lactam targeted antibiotics. So what's magic about cefazolin?
So they are both beta-lactam antibiotics, but they're two different types of beta-lactam antibiotics. So nafcillin is considered a penicillin in a penicillin group, and then cefazolin is considered a first-generation cephalosporin. So they both have similar mechanisms of action, but in regards to dosing, nafcillin is dosed a lot more frequently, either every 4 hours or continuous infusion. Cefazolin is actually dosed less frequently, every 8 hours. So they have very similar mechanisms of action, very comparable, so we thought it would be a good two options that would show similar efficacy in regards to treating MSSA bacteremia.
Now, what sort of study did you do? Was this an inferiority trial, or was it a placebo control? What sort of trial was it?
So this was a non-inferiority study, which is basically looking at are these treatment options equivalent? We're not saying one is better than the other, but are we would they be equivalent in regards to treatment outcomes?
So are they as good, if not better, is what you're going to get for your answer?
Exactly.
So what's the risk of continuing to use nafcillin? Is it a good drug for the patient, or does it have side effects?
The concern, previous studies have shown that nafcillin actually produces more adverse events compared to cefazolin, and we actually also found that in our study that more patients had adverse events on nafcillin compared to cefazolin. So that's a concern when you're treating these patients, because you don't want to start an antibiotic, find out that the patient develops an adverse event, and then have to change the antibiotic mid-therapy. So with cefazolin, with the fewer adverse events, they can continue on the antibiotic throughout the whole course with less concern of developing a potential event.
So what was your role in this trial?
So I was basically Maggie's project mentor throughout this project. So this was something that my colleagues and I at Parkland had kind of been thinking about for a while. And so when we had the opportunity and a willing resident who, who was interested in helping us out, we kind of just facilitated the project and helped her set it up, and kind of just served as project mentors and people who could help her along the way.
So this was an investigator-initiated trial. This wasn't funded by a company or anything else. This was because you guys were curious, wanting to effectively ask a question to better outcomes for our patients and better outcomes from the perspective of antibiotic stewardship. One of you can take the hard question: what is antibiotic stewardship?
So antibiotic stewardship is basically a broad term for making sure that antibiotics are used appropriately. So are they given for the appropriate indication? Are they given at the correct dose? Are they given for the correct duration of time? And that kind of encompasses a lot of things underneath the umbrella of antibiotic stewardship. So that could be things like looking at overall hospital antibiotic utilization. That could be creating hospital guidelines for treatment of specific infectious diseases, looking at outcomes of therapy with different antibiotics. So there are a lot of things that could be considered antibiotic stewardship. And so I think from a hospital perspective, this project was very interesting to the pharmacy administration, because certainly any time that you can bring efficacy along with cost savings, you know, that's kind of a mutual benefit. Yeah, exactly.
So there is a difference in cost between nafcillin and cefazolin. It is a different cost. Which one is less expensive?
So cefazolin is much less expensive. It ranges anywhere from 10 to 13 times less expensive than nafcillin.
Wow.
So if you look at patients, you know, some of these patients are being treated for 6 weeks, you know, with endocarditis, which is an infection of the heart, or osteomyelitis. They're on this therapy for a long amount of time. So when you factor in, not only is it 10 to 13 times less expensive, but multiply it by the days of therapy, that you're going to find significant cost savings.
So from a prescribing physician's perspective, how do you get this information out to them? Is it bundled in the medical record when they order for an MSSA infection? Does the order come up suggesting cefazolin, or does it come up suggesting nafcillin, or it gives them, they can make the choice themselves?
Well, when we started this project, we didn't really notice a trend in regards to physicians prescribing nafcillin over cefazolin or vice versa. So after doing this project, we really wanted to increase education, providing our outcomes, and you know, these are patients from our hospital, so we can directly apply this to our practice at this hospital. So it's just a lot of provider education, and we were both involved in the antimicrobial committee, where that entails pharmacists and physicians, and we discuss the outcomes and where we can go from there in regards to education.
How did they take the educational opportunities? Were they surprised? Did they embrace it? You know, how did you get it out? Was it a heavy lift, or was it an easy task?
So I think anytime that you can bring data to the table, it certainly makes what you're saying more believable and more, I guess, understandable and valid. Yeah. So I don't think that there was a lot of pushback or anything like that. I think everyone was kind of pleasantly surprised to see what we saw. And, you know, it's consistent with what previous studies have shown, but there's always a tendency to think, well, maybe our patient population is a little bit different. Can those results apply to our hospital's population? So I think that doing the study there kind of validated what other people have seen and made the physician group at Parkland more kind of receptive to the results that we found.
How long did it take to do this sort of study?
It was a full year's worth of work, so we started developing the methods of the study as soon as I started my PGY1 residency in August, submitted to IRB, started data collection in the fall, winter, and then completed data collection by spring, started analyzing and putting together a manuscript. So it was a full year's worth of work. Lots of hours.
Lots of hours. So you've since moved on. You've left beautiful Texas, and you've now since moved to Hartford.
Yes.
So are you continuing this sort of work in Hartford? And I'm going to ask Jessie, do you miss her?
Oh my gosh, so much. Maggie was a great asset to our team. She really helped make our day-to-day jobs easier when she was working with us. So there's definitely a Maggie-sized void at Parkland right now. But we're very proud of what she's doing up at Hartford and hoping that one day she'll come back to Dallas.
Ooh, your mother would be happy.
Oh yes, my mother would be very happy. But yeah, what I'm doing in Hartford is a little bit different in regards to study design, but it's great, learning different types of studies, so you can have that in your toolbox later on to be able to produce any type of study that you want to look at.
So from the consuming public, what sort of takeaway message should they take from studies like this? Is this a good thing that the PharmDs and the physicians should be doing? Is it going to really impact them immediately?
Right. I think a lot of concern that the public may have is, the research is just based off of healthcare savings in regards to hospital expenditure. But what this study looks at, this study can benefit patients as well. So, we're looking at both sides of the coin. We're looking at hospital and patient in regards to adverse events. Patients may be exposed to less potential for adverse event and savings. And like I mentioned before, patients can be discharged home on these antibiotics for long periods of time. With cefazolin, it's easier to dose, less burden for the patient, especially if they are on hemodialysis. You can dose it post-hemodialysis. So there's just a lot of benefits with cefazolin over nafcillin, and we don't want them to think that this is just for hospital savings. It's for the patient as well.
That's good to know. You're watching ASM Live here at ICAAC, and we'd like to ask the audience should they have any questions, please step up to the microphone. And those of you out in the Twitter sphere, please have an opportunity to come and ask your questions via hashtag ASM Live or via our chat room. We have a couple of questions,
Great.
It looks like, from the audience, and we'll go first.
Awesome.
Sure. Good afternoon. Good morning. It's Michael Smith from MedPage today. I have a bunch of questions if I can just run through them. First of all, the abstract describes nafcillin as standard of care. Is that just in your institution, which I guess at the time was in Texas, or is that broadly based? What makes you think it's the standard of care, given that both these drugs are generics, as far as I understand?
Right. With the endocarditis, we base that statement off the endocarditis guidelines. Although there's new endocarditis guidelines released this week, so it's important to refer to that as well. In those guidelines, cefazolin is actually listed as an alternative to nafcillin with a penicillin allergy. So it's most of the time in the literature, it's listed as the alternative to nafcillin. So that initially makes people think that nafcillin should be your first-line agent.
Okay, fair enough. Do the current the new guidelines say the same thing? Have they changed it?
That's what they're saying, is that
Cefazolin is an alternative. Okay,
another
fair
option.
Enough. Let's put some salt on the tail of cost. You said 10 to 13. So if I have a 5-week course of nafcillin versus a 5-week course of cefazolin, what's the difference in cost in terms of dollars and cents? Do you have any idea?
So when we looked at when we looked at all the patients in our study and calculated the cost savings, it was almost $100,000. So, that can be a full-time employee infectious disease pharmacist, or you can utilize that money for other resources when you apply that cost savings.
Okay, I got that's a huge number.
Yes.
I'm surprised that no one has noticed this before.
There have been studies, only recently in the past 3 to 4 years, other hospitals have looked at these outcomes and found similar results as well. So we just solidified it within our system.
Just to make sure I understand, the average cost difference of a patient treated with one or the other was $100,000.
That over the whole study. So that's 71 patients within the nafcillin group. If you switch them all to cefazolin, then it would be about $100,000.
For the 71
Yes,
patients?
for the
but not for
71.
each patient?
Not for each patient,
Oh,
yes.
okay.
I don't have that exact number for you, but
So
I
whatever
can give that
71
to
into
you.
100,000 is would give you the average?
Yes.
Okay, so phew, that makes a huge difference. I'm glad I asked that second
Yeah,
question.
you and the folks at CMS are breathing a collective sigh of relief.
I can imagine. You would think if it was $100,000 a patient, someone would really have noticed it.
Yeah.
Yes.
And let's put a little salt on the tail of the adverse events. You had the 71 patients in the, what sorts of adverse events are seen with the nafcillin? What sort, and how do they differ from those seen both in type and quantity for cefazolin?
So with the nafcillin, we actually saw a significantly greater amount of nephrotoxic events.
I'm sorry?
With kidney injury. So we monitored that, looking at their creatinine clearance and their serum creatinine and seeing if that's elevated or not. And over the course of the study, we saw several patients develop that in the nafcillin arm. This also has been seen in previous studies. So in regards to why that occurs is not completely 100% understood, but it's been reported in previous studies as well. And then as far as the cefazolin group, we had about 2 patients, 2 or 1 patients develop thrombocytopenia, nothing major, about 2 or 1 in each adverse event arm. So.
And the final question, and this you touched on, Michael touched on this, but has there been a change in practice in your hospital? Have you noticed that?
Nothing that we've seen immediately. I think that there are still some physicians who, we haven't made anything from an administrative kind of standpoint where we are requiring physicians to use one over the other. So it is still left up to physician discretion. So I think that if we do see kind of a swing in practice, it will take a little while.
Thank you.
Thank you.
Another question from the audience.
Hi, Bruce Jansen, Family Practice News. First of all, are the numbers in the abstract accurate?
Yes.
Okay, so what about that difference in the treatment failure rate? Is that a significant difference or too small?
So it is, in treatment failure rates, it is significant. There was significantly more treatment failures in the nafcillin arm.
Okay, and this wasn't a randomized trial, correct?
Correct.
So did you attempt to propensity score match the 2 groups?
Right, we did not propensity score match the groups, but when we did look at the patient demographics, we saw very similar results in both the arms. The only differences we saw was length of stay. The nafcillin arm had patients stay longer in the hospital, and we attribute a portion of that because in our hospital, the outpatient antibiotic therapy, they can be discharged home on cefazolin, where if they start nafcillin, they actually have to continue it in-house. We don't have the process to set up the nafcillin due to expenses outpatient. So patients on cefazolin can actually go home sooner, still receive the same amount of antibiotic therapy compared to nafcillin. So we think that was a portion of that.
Yeah, with fewer side effects, so
Yes,
they could go home
yes.
early. So is your title PharmD?
PharmD, yes.
Okay, thanks.
Yes.
Another question.
Hi, Mark Levin from Chicago. And forgive me if this was in the abstract and I didn't see it, but in terms of the patients you were treating, the ratio of people being treated for endocarditis versus catheter-associated infection, where you would give a shorter course, that's the first question.
Sorry, could you repeat that?
I guess I'm interested of all the patients you had in your study, endocarditis patients with Staph aureus versus patients with, say, just a catheter-associated bacteremia, where you would be treating with a shorter course.
Shorter amount of course,
Yeah.
that is correct. And that is one limitation to our study, is that we didn't have a lot of endocarditis patients. We did have a good amount, but in regards to what we were looking at with nafcillin versus cefazolin is something called the inoculum effect, which is where you see hypothesized failures with high-density bacterial infections. So when you think of something like endocarditis or osteomyelitis, and there's a lot of bacteria at that infection, previous studies, in vitro studies have shown that there's a concern for treatment failures with cefazolin. So that is the limitation to our study, is we didn't have a lot of high-burden infections, but yes, you would treat those longer, anywhere from 4 to 6 weeks with the high-burden infections compared to 5 to 7 days with other infections.
And you had 5 to 7 14-day people in your study,
Yes,
right?
we did.
So, and just the last question or comment, I think you're correct in terms of the IDSA guidelines for endocarditis. They do say nafcillin. For the catheter-associated infections, in terms of IDSA recommendations, I think they may give cefazolin as a major choice.
More of a choice.
in that type of setting. Thank you.
Thank you.
Another question from the audience.
My name is Philipp Arfeiner. I'm an infectious disease specialist in a small hospital in Switzerland.
Okay, hi.
Hi. I'd like to know, in the last years there was some concern about the production of Betalactamase type A, which could inactivate cefazolin. So did you test every Staph aureus for this Betalactamase A, or how did you do that?
So we did not look specifically at the production of beta-lactamases. We just looked at the type of infections that we saw, but in previous studies that did look at beta-lactamase production, they didn't see a difference in overall outcomes. The only difference they really saw was more persistent bacteremia in the cefazolin arm, but in regards to treatment outcomes, there was no significant difference.
Thank you very much.
Thanks.
So it appears from the questions that we receive from the audience that education seems to be our biggest limitation still. So I know that is a major challenge with antibiotic stewardship programs. So Jesse, do you have any pearls of how we might be able to to educate our prescribing physicians so that they learn of the opportunity that stewardship offers them in terms of demonstrating a better outcome for their patients and actually helping to lower costs for our hospitals?
Sure. So we kind of have tried to tackle the education piece from a couple different angles. I think certainly implementing order sets in your electronic medical record are probably one of the easiest ways to reach the most amount of people. So at Parkland, we do have a staphylococcal bacteremia order set where physicians can go in there and they can kind of see their options regarding recommendations for getting echoes, recommendations for treatment based on whether this is an MSSA or an MRSA infection. And so I think that's one of the easiest ways and probably one of the least time-consuming ways that you can reach out to everybody. Other things that we have done, our hospital, a couple of the different groups, the hospitalist group specifically do have monthly newsletters that go out, so we try and use that as a way to reach a broad number of people as well. And then basically just, I round with the ID team, so using that opportunity to educate the residents and the students who are on service at the time too, and hoping that they'll pass that information along no matter where they go after that.
Mm-hmm. We have a question from the Twitterverse. Nope, no questions from Twitter. Well, if there are no other questions, do you either of you have anything else you'd like to offer our audience here this morning?
If you think of any further questions later on today, like you said, I will be presenting my poster tomorrow from 11 to 1, so feel free to stop by.
Well, you've been watching ASM Live here at ICC and ICAAC. Please join us tomorrow at 10:30 Pacific Daylight Time. We're not get quite into standard time, where we're going to have another session of ICAAC Live. And this and all our other ICAAC Lives are archived at ASM's public website, microbeworld.org, where you can have an opportunity to review this session as well as all our other ASM Lives. And if you're interested, you can check out one of ASM's fine podcasts. This Week in Microbiology, This Week in Virology, This Week in Parasitology, or our newest offering, Microbe Magazine, the Microbe Magazine podcast. And I'd like to thank my guests, Dr. Jessica Ortwine and Dr. Maggie Monogue, who are from the Hartford Hospital as well as Parkland Memorial in Dallas, Texas. So until next time, follow us on This Week in Microbiology. I'm Michael Schmidt for TWIM. Thank you, and goodbye, everybody.
Thank you. Thank you.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shock.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an R scan. So the HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right? Remember, this building is basically a second building inside the main building.